Well, we've already given you the highlights of his career. Please just put your hands together and welcome Dr. Anthony back to the stage. We're keeping him busy, by the way. You saw him the first presentation. This one, he'll be up on the as one of the panelists running the panel. So here you go.
Okay. Yeah, it's a real pleasure again to be back to talk to you about the next stage of understanding neuroendocrine tumors. I'm going to get maybe a little bit closer to you so we can maybe start a dialogue. So the introduction before just an overview now, I really kind of want to drill down on mediators and specifically serotonin. This is really one of the most exciting substances. I have to, somatostatin has been transformative in our using and understanding biology and using it as therapy has been absolutely transformative. But understanding serotonin has become just as relevant, just as important, and just as challenging. Where do you get serotonin? Where does serotonin come from? You don't eat it, but you do get it from your food, from tryptophan. You do not eat serotonin. Now, you can buy serotonin tablets and do that. I don't think that, I'm not a big proponent of supplementing normal diet. I mean, if people have reasons for supplementation, it's different, but as a general reason, there's no real reason people should be on serotonin. Taking serotonin supplements, it's a little nutty. I'll just stop right there. It's just, but tryptophan in the diet, this is an amino acid. Where does tryptophan, what foods are rich in tryptophan? Turkey, is that what I heard? Well, how about things that increase your urine serotonin so that when you do a 24-hour urine collection, they tell you not to take? Anybody know those foods? Avocados, bananas, pineapples, nuts, kiwi fruit, tomatoes. This was actually on my board for medical oncology. I couldn't believe it. It looked like nutrition boards. What foods are serotonin rich? So tryptophan is dietary, gets converted into serotonin in 2 easy steps. You hear 2 easy payments, 2 easy steps, 2 easy steps. Yeah, 2 easy steps. The first one's rate limiting, and this is tryptophan goes to 5-hydroxytryptophan. Simple enzymatic reaction. And then some magic goes along where there's a decarboxylation, that's a fancy term in chemistry, where the molecule gets a little bit smaller and it gets transformed into serotonin. Okay, where is serotonin found? Most of it, 90% in the gut. Gut. You probably think of serotonin being the feel-good hormone, brain, right? I mean, isn't that right? Brain, serotonin, SSRIs, the serotonin selective receptor inhibitors, the whole aspects of depression, SSRIs. So what does SSRIs do? Increase brain serotonin levels, the neurotransmitter between nerves. It increases the levels. So when you think of serotonin and mood, then brain becomes the key thing. But most of serotonin's in the gut. 90% is gut. And then what's circulating in the blood, in the platelets, comprises the second most highest component. So most of it in the gut, second in the blood circulating the platelets, third, about 2% in the brain. You'd almost think it's the other way around, right? The importance. So when we think of carcinoid, what carcinoid tumors do, we're making a product that's going to be acting on the gut. It's not going to be this serotonin outside the brain is not getting into the brain. So it's 2 different compartments. So when you have a big turkey meal and you get sleepy, what's going on there? But that's really not turkey. You really can't blame that on turkey. You just have a big meal, postprandial sleepiness, drowsiness is physiologic. Turkey gets blamed because of the big meal at Thanksgiving, Christmas, or whatever. But it's really a whole aspect of this, what's going on in gut physiology that's causing that phenomenon, not related specifically to tryptophan or turkey. So we know that serotonin is stored, it's made, and it's stored in these granules. So the neuroendocrine tumors are working overtime. That's all they do. Well, they do a lot of things, but they're making a lot of serotonin. They're pumping into those vacuoles, into those, storing it, so that when you do drink some alcohol, you do bend over, those vesicles, or they fuse with the plasma membrane, they release those substances into the blood system, and you have symptoms. So it's stored serotonin that causes the problems. The CNS makes its own serotonin. It's beautiful biology. There's two different enzymes that convert when we talk about tryptophan, 2 easy steps going to serotonin. The enzyme that does that first step, there's 2 different isoforms. I know that's a fancy word, and you say, oh my God, isoforms, what is that? So that means that there's 2 distinct enzymes that are cousins. They're not exactly the same. So one isoform is outside the brain, and one isoform is inside the brain. So when we try to inhibit serotonin with an inhibitor that goes into the CNS, then we get into too many CNS problems by inhibiting brain serotonin. Then we get depression. But when we have an inhibitor that inhibits isoform 1 that it lives outside the brain, we don't affect brain serotonin. It's almost too good to be true. I guess you never know where you are unless you look back to where you were, how this got started. We can look at an Italian, Erspamer, for crediting the early discovery of serotonin. He found a substance in the gut that caused a contraction. This was 1935. Phenomenal work. Didn't know what it was. And he didn't call it serotonin, he called it enteramine. It was a small molecule that derived from the gut, the enteric. It took a few more years, and cardiovascular researchers at the Cleveland Clinic, 3 of them, to put it all together. So they worked on the vascular side. So basically it's serotonin circulating and it's stored in the platelets. In about 1952, they figured out that enteramine and serotonin was the same substance. So serotonin, the seral part of serotonin is in the serum. The tonin part is tonic, the tone of the blood vessels. So it's really a beautiful word that communicates what it does. So serotonin's action physiologically is really quite broad. It functions as a neurotransmitter in the CNS, and within the CNS, not only is it regulating mood, but through the vagus nerve, it also impacts what happens in the gut. So the gut is getting it from the central as well as for local, what's happening locally. And that local mediator is the motility and potentially inflammation. And this is where infections, C. diff and H. pylori, and these infections that can affect the GI tract. And we know it's vasoactive in the blood. So we know most of the serotonin is outside the CNS, and it resides within the gut. Okay, so this is a listing of all the things that serotonin does. This is just normal physiology and things that can happen in the body. Complex regulation of heart rate. So serotonin is involved in the regulation of the sinus node. It can induce atrial fib if the serotonin states get really high. It's involved in the heart development embryologically. It's involved in the valvulopathy. It's involved in remodeling the ventricles in chronic congestive heart failure. It regulates respiratory drive, may be involved in sudden infant death syndrome. It's involved in the pathogenesis of pulmonary hypertension. It regulates gastric emptying, intestinal peristalsis, intestinal secretion, colonic tone, pancreatic secretion, may regulate the beta cells of the pancreas, nausea and emesis, irritable bowel syndrome. Platelet drive may be involved when the liver is cut and the liver regenerates. It's involved in those regenerative signaling when the liver heals and grows. And then from a pain nociception, and then on the effects from the hypothalamus to the pituitary to the adrenal axis, we call that the HPA axis, and stress responses. So serotonin is hitting it from all aspects of physiology and biology. So we think so the general signaling mechanisms are shown here. There are 18 genes that code for the receptor, serotonin receptors, and the transporter. So the receptors are important to cause the effect of what the modulation, the communication, what the molecule does. The transporter has to do with moving the product out, getting the substance out of that compartment, and it's not necessarily signaling on that. So we can think of it as metabolism, getting rid of the product, not having the serotonin activated. So with all that, 10 additional proteins, multiple isoforms with creating at least 10 additional proteins that go on here. So it's very complex as it relates to the system that controls it. So here we have an enterochromaffin cell, and this cell is buried in the villus of the lumen of the gut. And as the serotonin is synthesized and released, there's target cells, and these are receptors that are coded in 5 different types and subtypes of receptors. And then the transporter protein is just as key to get the levels down and move them out when it gets too high. So this is a cross-section of an intestinal villi. So what we have here is the lumen, and this would be the wall of the gut. At rest, we can see a goblet cell. So this goblet cell secretes mucus. This lubricates. We can think of lubrication of the GI tract provided by that cell. These are enterocytes. These are the normal cells of the gut that causes secretion, that puts out fluid and does other things, has immune activities as well. And then the EC cell, the enterochromaffin cell, is buried here is in the crypts, in the villi crypts. When there's stimulation, then the serotonin gets secreted from those vacuoles. So it's already made the serotonin. It's waiting for something to happen. So some mechanical stimuli comes along and causes the secretion. That secretion now comes along and touches the myenteric plexus. And so this is part of the peristaltic mechanism. Some of it gets absorbed into the blood, and the platelets then will absorb it. So the platelets don't make serotonin, they store serotonin. This is part of the problem when we try to measure serotonin in the blood. We have to be, do we look at serum or plasma? And then where the serotonin gets taken back up, there's a transporter in these enterocytes. That's where the serotonin transporter is. So that's getting rid of the local serotonin. When it gets too high, then that transporter is getting it back into a cell to have it degraded. Not only is serotonin made by those enterochromaffin cells in the gut, but it's also made in the nerves. So serotonin is a neurotransmitter in the myenteric plexus in the gut, outside of what the gut is telling the myenteric plexus to do. So if the gut's happening to the gut can secrete serotonin and tell that plexus to move along, then the plexus itself is using serotonin to talk to neurons downstream. And this is where tryptophan here is synthesized, and so it has its own vacuoles. When necessary, those vacuoles fuse with the outer membrane of the cell, and then those contents are pushed out, and then the next cell, the next synapse below, the next neuron below that is stimulated. So this shows here the gut, and there's longitudinal and circular muscle in the myenteric plexus, so this would be the end organ of effect. This shows, again, the effector loops, the serotonin, and how it's integrated into the regulation. This has the enterocyte, the normal cell. This is that enterochromaffin cell that gets the signal from the lumen, like a mechanical, something's going on there, maybe infection, maybe something toxic is coming through there. The enterocyte, it also feels it, but the enterochromaffin cell now gets really busy and starts pumping out the serotonin. The serotonin then is going to be increasing peristalsis, and whatever is noxious or toxic is trying to be pushed out of the gut lumen. So the enterochromaffin cells then, these are the cells now that look and become malignant. They reside along the epithelial lining. They obviously play a crucial role in regulation, GI regulation, both motility and secretion, both. So I've emphasized more, I've shown you more on the motility side, but the secretory portion is also important, is also critical. The enterochromaffin cells are the most common neurocrine cells of the GI tract, and we can see that they exist not only in the small bowel, but colon, and usually we see them as you saw in the base of those intestinal crypts. So you can see now that this is sort of an orchestra where there's the wind section and the string section and the horn section. You can kind of see when the body comes together, you've got GI hormones and enzymes and all this signaling going on. And when this occurs, then you have the normal situation of digestion and health, and everything acts accordingly. But when there's pathology involved, you can kind of see where one of these members of the orchestra starts to bleed out and you can't hear the horn section and the string section's taken over. You no longer have an orchestra and you have to sort of try to fix it. And this is where I think where we really are focused on dealing with from a disease standpoint. And so carcinoid syndrome would be that specific disease that would be manifested when something goes awry. There's too much of something. So the syndrome we've talked about being the release of serotonin and these other substances that causes the flushing, potentially, those other substances P, the diarrhea, the bronchospasm. So what we want to do in the 1980s is we figured out that if we use somatostatin, we suppress the release of these vasoactive substances. We're not inhibiting the synthesis, only the release. Well, that was huge. By 1985, it was huge. When we only really had maybe interferon, and before that, we basically had morphine and cyproheptadine to help control things, and then it came along interferon about 1979. By 1985, we had the somatostatin analogs. Somatostatin analogs, by inhibiting release, was huge, but guess what? About a third of people really didn't inhibit a release enough, and it was too short. So it was a step forward, but clearly needed to be improved. So when serotonin chemistry was worked out in the 1950s, researchers at that point figured out, gee, if we block it, we could maybe fix carcinoid syndrome. Carcinoid syndrome was put together in 1954, the mediators. And so as this works out, this is not inhibiting the release of the synthesis of this is not something that's just modern. So by about 1967 or so, the group at the NIH had put together a molecule called parachlorophenylalanine, PCPA, parachlorophenylalanine. So this was an inhibitor of serotonin. Problem was it got both isoforms. It got into the CNS. It worked. It did what it was supposed to, but it had too many side effects, died on the vine. Even by the 1980s, people were still trying to bring it forward. So in neuroendocrine tumors, there's a autocrine loop that has been identified in these tumors where serotonin receptors exist on the cell surface. This is HT types 1A, 1B, and here is type 2. And these subtype of serotonin receptors, this shows you the complexity, these subtypes activate different subcellular pathways. These pathways have been implicated in cellular proliferation, and you can see where there's serotonin being secreted. It feeds back on these receptors on the same cell and forms a stimulus to keep the cell growing and stimulated itself. And this work has been done in a number of cell lines, the NCI H727, the H720, and the KRJ, and also the bond line. So this chemistry and physiology is across multiple tumor types. So when you think about serotonin in tumors and tryptophan, if you've got too many tumors, is it acting as a sink? Is it just sucking up all the tryptophan? So when you flip the coin and say, when you eat tryptophan in the diet, where does most of it go? It's not serotonin. It really goes down other pathways into niacin and to other pathways that have to do with sleep. And so that gets into a whole different scenario, but it's all tryptophan. Tryptophan is the only amino acid that has its own professional society. There is a tryptophan association. There's a formed by the Italians. It's kind of interesting. It goes back to Erspanger. But it was formed in the early 80s. Tryptophan is such a huge amino acid. It has its own society. I think it's phenomenal thinking about it. And that serotonin in this society, when you go and you look at what they talk about, serotonin is not a major component of their talks. They're really interested more in the other aspects of tryptophan metabolism, where 90% of it, so only about 10% of it goes down the serotonin pathway. 90% goes somewhere else. Where this somewhere else is the immune system. And that's where we're just now starting to understand how tryptophan and serotonin and these other pathways, how it all interrelates. If we block the formation of serotonin, what does that do to tryptophan? Does it shunt more over into the kynurenines? That's a great word to remember, kynurenine. So that's the metabolite of tryptophan that is not serotonin. So everybody in the room probably by now has heard of 5-HIAA, 5-hydroxyanilacelic acid. So tryptophan goes to 5-hydroxytryptophan, goes to 5-hydroxytryptamine, which is serotonin, and then it gets metabolized to 5-hydroxyanilacelic acid. And you're done. That gets secreted in the urine, you're done. So those metabolites are not active. So most of that, once it gets to serotonin, most of that metabolism goes down a different pathway, not down 5-HIAA, but it goes down towards the kynurenines. And what the kynurenines can do to dendritic cells is it can induce immune tolerance. So if you do if you think, oh my God, if we block serotonin degradation or stuff, and we're taking tryptophan and we're metabolizing tryptophan through other pathways, we're actually going to be inhibiting the immune system by shunning it in the wrong direction. So this is the complexity of biology. It's not that easy, but that's the intuitive sense, is that tryptophan too much could play a role in the immune system in a negative way. And that's part of the work that is going forward now, and you'll start hearing more about that in the future. So this immune escape drives the development of tumors, and that's the mechanism that's being put forward now, is that the tryptophan going down those other pathways besides serotonin. Okay, when we think of carcinoid syndrome, what are all the many symptoms that are connected with it? Well, the most common is flushing. Right after that is diarrhea. Now, we have to look back and see that a lot of these data are being captured, they're being reported out in the first decade of the century, but really it's kind of older data that comes from the 1970s, 1980s. And we, at this point, hear heart lesions in 50%. Once the somatostatin analogs came along, we're suppressing it. Cardiac lesions are nowhere close to what they used to be. We're very concerned about it and very focused on it. We don't take it for granted they don't occur. But I've been at Kentucky now for 8 years. I've probably seen more than 1,000 carcinoid patients in those 8 years. I think I've sent one to cardiac surgery. That was somebody I inherited from another provider. And within a year, that person went into florid heart failure. That patient went to cardiac surgery. So I see on my side, I don't have the experience, thankfully, of having a lot of carcinoid heart patients. I think that's a success. Mayo Clinic in Rochester, you have to, they've got several, you have to go to Rochester. They've got the most experience because they focused on carcinoid since the 1960s. So they have an experience. They say that carcinoid heart disease hasn't changed any. This shows you how referral bias is so great. I don't see it anymore. I prevent it, and hopefully the ones I do see are the ones that are managed by someone else. Telangiectasias, the little tiny blood vessels that are seen, is not more of a symptom, but it's a sign. Edema. Edema is vague. That could be from heart failure. It could be from some drugs that we use will cause edema. Cyanosis. So you can see a whole list of things. I'd love to see an updated form of this. These are very difficult things to try to tease out of tumors, of the literature. So part of the problem that we see is that whenever these episodes happen, it's episodic. And that's why we don't want our patients flushing, because when you're having symptoms, then the body's being exposed to these noxious chemicals, and we really would like for that not to be the case. And diarrhea has been recognized as to be the most bothersome symptom of carcinoid syndrome. And that basically is probably more discomforting in their quality in their daily lives, but I have seen some people from flushing lose their jobs because every time they flush, their coworkers think they're mad at them, and it becomes intolerable environment, and they have to leave. I mean, it's interesting. So I respect what flushing does to daily activity as well. And so we have to really look at serotonin and all its mediators being responsible for taking down people's quality of life. So we've gone through this pathway several times. Hopefully by now you understand it's tryptophan in the diet. It gets absorbed, it gets metabolized in the tumor cell, metabolized in the adenochromaffin cell, metabolized in the CNS, stored in the vesicles, stored in the platelets. So once it's is in the blood, then the kidneys will filter it and take out the metabolite. And so historically, when we measure serotonin in the blood, it's episodic. So it jumps up and down, in other words. So if you measure your serotonin levels at 9 a.m. and then get it at 9:30, it could be 50 to 100 points different. And so, but that's normal physiology. Serotonin just goes up and down. 5-HI does not. 5-HI is the end result of serotonin, so that when you collect a 24-hour urine, you're looking at the total production over 24 hours of what the serotonin has been in the body during that time frame. So it becomes the gold standard. Well, what's the problem in measuring 24-hour urine for 5-HIA. What's the problem there? And believe you me, in the 1980s, every patient I saw had to get a 24-hour urine 5-HIA or I wouldn't see him. Okay, and so you can imagine the conversations that I would have. It was a constant war. I saw patients at the VA, I saw patients at Vanderbilt. It's a constant war. If I did 5-HIA collections at Vanderbilt, they wanted acid in the jugs. If I did it at the VA, they did not want acid in the jugs. So I was sitting there saying, good gosh, they can't even, the lab can't even agree. So if you're going to get a 24-hour urine for 5-HIA, you have to go to the lab that is going to measure it and get the jug from them. And then guess what? Then you have to bring it back. So if I get a 5-HIA on somebody, they have to first of all get the correct jug. Then they have to go home, and then they have to go on a serotonin-free diet, at least for about 3 days or more, before doing the urine collection. And then they have to do a urine collection. How weird is that? And then they have to store the urine in the refrigerator. How weird is that? And then they have to carry it into the clinic. How weird is that? You can manage to get on an airplane with jugs of urine? So you can kind of see that in the 1980s, I was bogged down into the research part of it. We had to use a gold standard. We didn't have a choice. And now we have a choice. So I haven't done a 24-hour urine in my clinic probably since I landed in Kentucky. We all get blood 5-HIAs because A, the patient's there. They don't have to wait. We don't have to come back. We can follow it. And it just becomes practicality. So carcinoid heart disease, we can say, is one of the enemies. If you have carcinoid heart disease, we manage it better now. I think we can detect it earlier. We can intervene earlier. But we know that more than half the patients who have the syndrome, historically, when it's not controlled well, will develop the heart disease. And we think it's predicted on that 5-HIA level. These are just some examples of what the what the cardiologist sees. This is the tricuspid valve here that's leaky, it's thickened, not meeting in the middle. This is a jet of blood that comes through the open vessel, and this shows the thickened tricuspid leaflets of the valve that they don't meet in the middle, so that it becomes diseased and dysfunctional. So these are data that's been put together across multiple papers. But if you look at the level, the number of times it's elevated above the normal, you can look at survival, that the higher the level, people don't do as well. So you can look at quality of life. Quality of life is not as good. If it's related to 5-HIA, then survival is not going to be as good. So it's all tied in to quality of life and what's causing the deterioration in quality of life. And then the 5-HIA levels here are shown in an increasing incidence with the incidence of carcinoid heart disease is greater as the levels go higher. The second time I'll move through some of this. So we think of scarring in the heart, but I showed you a picture earlier of scarring in the mesentery with the wheel and spoke. It's a totally different chemistry. The mesenteric fibrosis is not exactly the same mechanisms. A lot of this work now is being done in Europe. They've not talked about it a whole lot, but there's a whole industry working on identifying mediators of mesenteric fibrosis and potentially altering the natural history here, because we know that the mesenteric fibrosis can cause havoc, so that people can live with the carcinoma tumor without any problems, but the fibrotic component of it can be lethal. So the lethal part of that is where the bowel, the gut, just doesn't work. It's blocked down. It may be shortened from prior surgeries. So the fibrosis does lead to a lower quality of life, and understanding that is different from understanding what's happening to the fibrosis in the heart. So this fibrosis also, the lung, skin, retroperitoneum. The retroperitoneum is the space that connects, let's say, if you look at the kidney down to the bladder, all that's retroperitoneum. We will see people's ureters get constricted from the retroperitoneal fibrosis. Everything else is doing fine, but that part of the body, the retroperitoneum, is becoming fibrotic, requires stents to be put through there. And that's something that we would love to avoid, but have to recognize it, because if that fibrosis is not dealt with, then the kidneys can be lost from the obstruction. So pulmonary artery hypertension can be just as severe as any symptom in carcinoid syndrome. This is something that's a little bit harder for us to follow. It's hard for us to measure the pulmonary arterial pressures, but we know from animal work, preclinical work, that serotonin stimulates hyperplasia of smooth muscles of the pulmonary artery cells. That these are increased in patients who have pulmonary arteries hypertension. So the work that's been done clearly shows that serotonin is a mediator of that. So the other part is that serotonin may be related to tumor growth. These are just survival outcomes in people who have had high serotonin levels and lower serotonin levels. You can see that if you look at just that mediator, it's best to not have an elevated serotonin level. There are a number of animal models that have been looked at that have shown that serotonin may mediate the crosstalk between tumor cells. And this work is going on in cholangiocarcinoma. We actually have a study opened at UK. It's opened at other centers looking at blocking serotonin in some of these other malignancies besides carcinoid. Because we know serotonin can be a growth factor. We talked about how it feeds on itself. And we know that it's important in proliferation in certain cell lines that have been looked at. So this is a protein that gets activated when cells start to grow, and this is a hormone that gets secretion that stimulates cell growth. And so these are all cell lines that have shown serotonin, and blocking serotonin has a role in stimulatory that. And again, this gets into some other biochemistry and physiology that shows that blocking serotonin, stimulating serotonin, plays a role in cellular cell kinetics. So what we know is that if we can block serotonin, people's symptoms from the syndrome get better. This was the transformational data that was published in the New England Journal in 1985. Larry Coles and his group at Mayo Clinic. This was really the study that got octreotide on the market. It only took 25 subjects for the FDA to say yes. It's pretty phenomenal. And the response, you can see the majority of patients responded, and the months on treatments are shown here. And so other aspects of it, we've talked about tryptophan hydroxylase being that early initial enzyme that makes serotonin. If we block that enzyme, this is what we can do with this drug, telotrestat. We can inhibit the formation of serotonin, and this was a study that got telotrestat on the market a few years ago, and it was an inhibitor of diarrhea, not the tumor. And so a lot of work right now is now saying, is there an anti-tumor effect? We're seeing people probably live longer on telotrestat than what we've seen. It's not a scientific study, but going through, and we've published these data to say that the drug is safe and that people do better. This is the registration trial just showing that the incidence of diarrhea came down, control of diarrhea was better when people were on somatostatin and not being controlled. And control was average of 4 or more stools a day. So with telotrestat, we could take that down by 1 or more. And it was a durable effect, not just a short-term effect. We also could lower the 5-HIA. So you can see now, if 5-HIA has to do with carcinoid heart disease and how long people live, we can not only improve GI function, lowering bowel movements, but we can also potentially influence how long people do with being exposed to 5-HIA. So we know that serotonin is overproduced as the driver of the carcinoid syndrome. We know it plays a central role in carcinoid heart disease, mesenteric fibrosis, pulmonary hypertension. It's been demonstrated to have a stimulatory growth on tumors in vitro, and and the control of this is important to the quality of life and the prognosis of people with carcinoma syndrome. So I'll just stop right there. Thank you.